Welcome, everyone. The Military Women's Health Research Series is a joint webinar series that's sponsored by the Uniformed Services University Military Women's Health Research Program and the National Institute of Health Office of Research on Women's Health. This series will focus on crucial research topics within both women's health and military women's health. Webinars are held monthly on the second Thursday of each month at 3 p.m. Eastern Time. Each webinar will highlight different topics and speakers relevant to military women's health. This month's topic is musculoskeletal and bone health. Next month, the October 9th webinar will be focused on cancer. I'm Dr. Lynette Hamlin, the Director of the Uniformed Services University Military Women's Health Research Program. The mission of our research program is to promote, manage, and coordinate the research that will improve the health of military women through interdisciplinary collaboration and policy recommendations. I would also like to introduce my colleague, Dr. Xenia Tigna, who is the inaugural Associate Director for Careers at the National Institute of Health Office of Research on Women's Health. Our goal through these webinars is to bring together leading experts in women's health from the Department of Defense and the National Institute of Health to share valuable insights and research findings. We are committed to highlighting critical areas of study and fostering collaboration in this important field of women's health. Each month, I'm going to give you a different fun fact about women in the military. So while 30,000 women served in World War I and 400,000 women served in World War II, it wasn't until the Women's Armed Services Integration Act in 1948 that women were allowed to serve as permanent regular members of the armed forces. As we get started today, I'd like to introduce some of our team members providing support for us behind the scenes. Dr. Carolyn Bondar, Program Officer at the National Institute of Health Office of Research on Women's Health. Dr. Angela Simmons, Associate Director for Research for Uniformed Services University's Military Women's Health Research Program. And Ms. Christy Kennedy, Program Manager for the USU Military Women's Health Research Program. They will be our team moderating the question and answer session later. Please note that the chat has been disabled. You will need to enter your questions in the Q&A section on Teams. Please note that while we recognize not everyone is going to have access to the Q&A, we do have limited time for questions at the end of the two presentations. If your question does not get addressed, we encourage you to reach out to the presenters after the webinar. You can also contact our team member, Christy Kennedy, and here is our email addresses for you for additional support. Following this webinar, we will do our best to share a copy of the presentation recording when it's available. They will become available on the Uniformed Services University's YouTube channel. We're excited to share that we are pleased to offer human-generated real-time captioning during today's event to ensure that all attendees can fully participate. You can access the stream text link through the Q&A section or by scanning the QR code displayed on this slide. Before I introduce our first speaker, I'd like to make a few announcements. First, please note that this webinar today does not offer continuing education credit, but I'm excited to share that our annual USU Military Women's Health Research Symposium that was held at the AMSIS meeting this past March has an enduring activity available for CEUs and CMEs. The QR code can be found on this slide. This is a 3-hour activity with speakers on a variety of topics related to military women's health. For those of you looking for continuing education, this is a great opportunity to receive credits. We also encourage you to mark your calendars for our third annual Military Women's Health Research Symposium. This will be held at the AMSIS annual meeting on Wednesday, March 4th, 2026, from 2:30 to 4:45 p.m. Eastern Time at the Gaylord National Harbor in Maryland. This year's session will focus on building a medically ready force through research, evidence-based practice, and policy. Please use the QR code to see more details on the AMSIS conference. Attendings for this program must also register for the AMSIS annual meeting. Lastly, our program has created a forward-facing military women's health research database, which can be found by Googling Military Women's Health Research Database or the link that you see on your screen. I now have the distinct pleasure of introducing our first speaker, Dr. Megan O'Connell. Dr. O'Connell is a scientist at Henry M. Jackson Foundation in support of the Defense and Veterans Center for Integrative Pain Management, otherwise known as DV-CIPM, at the Uniformed Services University. She holds a doctorate degree in physical therapy from the University of Pittsburgh, master's in analytics from the Georgia Institute of Technology, and is a board-certified sports clinical specialist through the American Physical Therapy Association. Her expertise resides in leveraging real-world big data in healthcare settings to evaluate clinical outcomes and inform policy. Prior to her work in research, she worked as a physical therapist in sports medicine, working with a wide variety of musculoskeletal diagnoses. Her presentation is titled Exploring Care Pathways and Treatment Patterns for Musculoskeletal Conditions. Please join me in welcoming Dr. Megan O'Connell.
Thank you, Dr. Hamlin, for the introduction. Today I'll be presenting on some of our team's work on women's health with respect to access to care for musculoskeletal injuries, after going through a brief overview about the significant impact of musculoskeletal injuries across the military, particularly for women. Next slide, please. Standard disclosure, this is just a list of the sources of funding for the research I'll be presenting on, and all viewpoints are mine and not necessarily representative of the DoD, Uniformed Services University, or Henry M. Jackson Foundation. Next slide, please. Musculoskeletal injuries have a huge impact on the military health system and on service members starting early and extending onwards even after their military careers, especially for women. And I'm going to highlight a few studies demonstrating the longitudinal impact of musculoskeletal injuries. Starting early in the service member's military career, research has performed on trainees entering initial entry training for the Army. Of trainees with a self-reported musculoskeletal injury on a survey, 64% will not report the musculoskeletal injury to leadership or a medical professional. While there isn't a difference in reporting musculoskeletal injuries between women and men trainees, which highlights some of the challenges we'll face when we work with observational data or are dependent on medical records, there is a significant difference in self-reported musculoskeletal injuries on surveys, with 58% of women trainees reporting a musculoskeletal injury compared to 36% of men trainees, with women trainees being more likely to not report a musculoskeletal injury due to the risk of being on profile. With respect to active duty service members, women have close to a 50% increased incidence of having chronic pain relative to men active duty service members. Similarly, when we look at service members post-military career, women veterans are more likely to report multiple pain conditions, with more than 20% of women veterans reporting at least one musculoskeletal injury diagnosis. In addition to multiple pain conditions, of veterans reporting a pain condition, approximately 41% of women veterans will report of 4 or more, which the study defined as moderate to severe pain, on the numeric rating scale, compared to 34% of men veterans. Given the significant impact of musculoskeletal injury across time in the military, it's particularly important to look at access to care and ways to mitigate the impact of musculoskeletal injuries. And as a physical therapist, I want to fully acknowledge the importance of preventing musculoskeletal injuries in the first place. However, the focus of this presentation will be surrounding our research on evaluating access to care, which could be a means to mitigate the impact of musculoskeletal injuries, such as reducing recurrent injuries, chronification, opioid usage, and other downstream effects. Next slide, please. As we talk about access to care and the work our team has done, we're going to take a tiered approach. We'll start by evaluating who receives care, regardless of the type of care received. Then we'll start to address specialty care received, more specifically physical therapy. And then we'll finish by looking at specific interventions and treatments that may be performed within physical therapy, as not all physical therapy treatments should be considered equal, and some physical therapy treatments will be more or less in line with clinical practice guidelines that exist than others. Next slide, please. In this first study, we looked at time to low back pain visit, and this is going to start at that global level of access, just who received any care. We looked at time to follow-up low back pain visit for active duty service members with an index low back pain diagnosis between June 2016 and February 2022 if they had no low back pain diagnosis in the prior year. Due to the heterogeneity of low back pain diagnoses, we did further exclude patients who had a traumatic or more severe diagnosis, such as cauda equina or spine fractures in that year prior as well, just because they would be at a higher risk of escalation of care regardless. As a side note for all the statisticians and research out there, all time to models that I'll be presenting on, we'll have covariates that have been modeled to allow for time varying effects using a piecewise exponential additive model, as we generally find that due to the variation in system level factors, the non-proportionality assumption is violated for the traditional Cox proportional hazard model. In the picture, the cumulative hazard difference is depicted. The cumulative hazard difference represents the difference between the cumulative hazard rates, while all other covariates except the one of interest is held constant. Other variables we control for in the model were your standard demographical variables, prior pain conditions other than low back pain, mental health diagnoses, substance use disorders, your trust and comorbidity index, and military treatment facility size. Here we can see that there's a lower cumulative hazard of receipt of a follow-up visit for female service members in the first week, which is then followed by a lack of statistical significance, with a statistically significant cumulative hazard difference presented at week 4, which continues to increase across time relative to male service members. Overall, female service members had a higher incidence of receipt of low back pain follow-up visit with an incidence rate ratio of 1.1. There could be multiple reasons for this finding, as prior literature has shown that female patients are more likely to be referred to behavioral health for chronic pain, and other research tends to show higher healthcare utilization by female patients, which could also contribute to the higher cumulative hazards seen from week 4 onwards. Next slide, please. Within the same study, after looking at time to follow-up low back pain visit, we then followed up and looked at time to an administrative action while controlling for the first few low back pain visits, as well as the prior covariates I mentioned. Our definition of administration action for low back pain was a co-documentation of a ICD-10 indicating low back pain, with the code indicating a form of disability evaluation, such as DoD codes indicating an integrated disability evaluation, medical evaluation board, temporary disability retired list, or an ICD-10 for disability determination, or an admin disposition recorded as medical board. As a disclaimer, not all these codes will result in permanent separation for medical reasons or receiving a disability rating, but they do represent an escalation with respect to severity. Despite the overall higher documentation that we mentioned in the higher slide for female active duty service members, across the entire 3-year span, female active duty service members had a lower cumulative hazard rate of receiving administrative action. While unfortunately we don't have the clinical information on clinical presentation, there's multiple possible reasons for this finding. Past research has indicated that female patients may be perceived more to be exaggerating pain and more likely to be referred to psychotherapy, while male patients are more likely to be referred to pain medicine, which may help explain this difference. Conversely, if we think back to that first study that was cited with respect to trainees, it could be that there's a survival bias for female active duty service members in that if they made it far enough into their career, which unfortunately is not counted here, but that also might reflect the difference. Next slide, please. Now the exciting part, or what I'm biased towards, time to physical therapy. Now that we talked about general access to care, we're going to get more into specific types of care, such as physical therapy. In the next study, we investigated time to physical therapy for active duty service members, retirees, and veterans with low back pain. Both the VA and the Department of Defense have released policies offering guidance on implementation of a step care model, highlighting the need for accessibility of non-pharmacological services to manage pain, such as physical therapy. Additionally, in general, early physical therapy has been found to be superior to delayed physical therapy, with some literature supporting early physical therapy to decrease opioid prescriptions and decrease overall healthcare utilization. The caveat I'm going to mention now, and I'll bring up again later, is that some of this research also matters not just about time to, but adherence to clinical practice guidelines to achieve optimal outcomes, which again, we'll address later down the road. Here, we're just focusing on time to initiating physical therapy, which was defined by having a presence of a physical therapy evaluation performed by a physical therapist after having an index diagnosis of low back pain. Similar exclusion and exclusion criteria were applied, as I mentioned in the last study, with some additional exclusion criteria. Patients were excluded if they had physical therapy in the prior year, as there's considerable overlap in how you would treat a hip and how you would treat the low back pain. And additionally, you also remove a little bit of the bias that might come with preconceived notions of physical therapy. If they had a good or bad experience, that may alter who attends physical therapy in the future as well. The only other additional exclusion criteria was if someone had a diagnosis that could be misconstrued for low back pain, which this may alter again who attends physical therapy. On average, female patients had an average hazard ratio of 1.09 relative to male patients. While the increase in female patients attending physical therapy may be warranted due to the increased pain and chronicity that was mentioned in the literature before, it's important to note that there may be other factors that alter the propensity for female and male patients to seek health care. Retirees and veterans both had significantly lower hazard ratios of receiving physical therapy across time relative to active duty service members, with an average hazard ratio of 0.39 for retirees and 0.33 for veterans. We postulated that some of the increased incidence of active duty service members seeking care could be due to the need for readiness, while the lower hazards seen by veterans and retirees may be due to ease of access, as approximately 1 in 4 veterans live in a rural area, which could make access more difficult. Although I do believe the Veterans Health Administration has shown that for veterans living proximal, they do have good access to care. While we didn't include an interaction term for the study, I do think in the future, looking at access across beneficiary groups for females and male patients would be beneficial. Next slide, please. We're now going to start to transition on from time to kind of looking at aspects of physical therapy. And as a quick disclaimer, the research presented from here down are preliminary unpublished findings. We just talked about time to physical therapy, which again, early PT has been associated with positive outcomes. However, when you look deeper at the research, you can generally see that it's early guideline adherent care that is associated with positive outcomes. So we wanted to better understand what an episode of physical therapy consisted of. In an attempt to capture the variation of care within a single system, this work focused on active duty service members with a low back pain diagnosis that was with an initial evaluation that occurred within 90 days. There are numerous characteristics that can be used to describe an episode of care, but before describing it, it's important to capture who had a single visit versus having an episode of care that can truly be characterized. We controlled for similar covariates cited before, as well as complexity codes, which were based off of CPT codes used for initial evaluation. This particular finding is probably in line with what you would anticipate based upon the prior work, with female active duty service members having a 10% lower odds of receiving a single physical therapy visit relative to male active duty service members, and higher complex patients having a 29% lower odds of receiving a single physical therapy visits relative to low complexity patient. As a side note, and I'm sure anyone that's dealt with observational data understands, the unknown complexity represents the use of the old CPT code that should not have been being used during this time frame. This is just represents the joy of utilizing medical and claims data. Fortunately, most people did actually code appropriately. Now that we know who had a single visit PT, we wanted to look at the variation of care that existed for those patients having more than one visit of physical therapy and what patient and care level characteristics were associated with those episode of care characteristics. Next slide, please. We went about exploring variation in care in a little bit of a novel way by utilizing a clustering technique called K-means clustering, which performs groupings of variables based upon their proximity to each other. The characteristics we were interested in were continuity of care, which represents the consistency of which a patient sees the same provider, better continuity of care, or more consistently seeing the same patient by the same providers has been associated with lower low back pain related healthcare costs, reduced likelihood of future spine surgeries, and improved functional outcomes in patients with neurological impairments. With the metric we chose to use to capture continuity of care, it was a scale -1 to 1, with 1 being considered to have kind of the best continuity of care you can. Maybe you had 5 visits and all 5 were with the same provider, versus you had 5 visits all with different providers. That would be a negative score. We also looked at the type of physical therapy received, which was based on CPT codes and categorized as either active physical therapy, which would be your neuromuscular control, CPT codes related to exercise, or manual therapy, and then also grouped into passive physical therapy, which would be things like mechanical traction, ultrasound, and heat. All these therapies were represented as a percent, indicating the number of days that at least one of these codes was received, divided by the overall number of visits. Current clinical guidelines strongly support the use of active and manual therapy, while passive physical therapy has been associated with an increase in opioid prescriptions, spinal injections, and an increase in specialty care visits. The last characteristics of interest were length of episode of care and number of physical therapy visits. These characteristics are a little bit more elusive. A relatively recent systematic review found limited evidence that higher utilization was associated with functional improvement for those individuals with low back pain, but may lead to improvement in downstream healthcare utilization for more complex or chronic low back pain. However, it was a relatively small number of studies, about 8, and so this is an area of research that needs to continue onwards. As a quick side note, how we define these, we define each variable, and what we defined as an episode of care was from the first physical therapy visit, defined as initial evaluation, and whatever continued to see a physical therapist without a 90-day lapse between visits. Next slide, please. The clustering of characteristics yielded 7 groupings. The largest group, most standard grouping, became our reference group, which consisted of an average of 4 visits over 27 days. Almost all visits, I believe about 88%, had active care, with only an average of 6% passive and 7% manual physical therapy codes being utilized. Overall continuity, which is on a scale of -1 to 1, with 1 being ideal, just to remind folks again, was relatively poor at -0.43. We then looked at patient level and care level characteristics associated with each cluster of treatment in a multinomial logistic regression. Female active duty service members had a higher odds of being in cluster 3 and 5, which were both associated with a longer episode of care and higher number of visits, with an average of 10 visits over 91 days for cluster 3 and 24 visits over 179 days for cluster 5. In addition to a longer episode of care and number of visits, cluster 5 had on average 37% of the days of treatment had a passive treatment code, and 41% of the days of treatment had a manual physical therapy treatment code. While the higher utilization may be due to chronicity or more severe pain, and unfortunately, again, we didn't have those clinical features to examine, it doesn't warrant further investigation to see if continued physical therapy is beneficial or if patients maybe should have been referred out earlier. This also highlights the need for more standardized use of functional outcome measures in the clinical setting to help understand who is benefiting from continued care. Next slide, please. The last specific intervention we looked at was with respect to receipt of dry needling across the military health system for all beneficiary groups, though over 90% of the cohort were active duty service members. As a disclaimer, the study is very exploratory. There hasn't been a lot of dry needling research done on real world data. We explored patients who were, I'm going to call them dry needling naive, which when I say that, I just mean they hadn't received dry needling in the year prior, and they could have received dry needling for any musculoskeletal diagnosis. After we described the cohort, we then looked at who had a follow-up dry needling visit within 90 days. Again, similar to the findings with respect to low back pain, any low back pain visit, the first week was associated with a decrease in hazard ratio for female patients, followed by an increase that existed for the rest of the observational period. On average, female patients had more dry needling visits over the course of 6 months. While similar to what has been mentioned earlier, utilization was higher among female patients. And this is in general for everyone, it's not really clear on the proper dosage, and our future work hopes to elucidate temporal patterns and dosing of dry needling to optimize outcomes, which is understudied in research. Next slide, please. So overall, to kind of summarize some of the findings, our findings are similar to what has been expressed in the literature in the civilian population and other specialty fields across the military, in that female patients had higher healthcare utilization on average, which again could be due to chronicity and higher pain scores, though we unfortunately don't have the granularity in data at this time. Despite the overall utilization and therefore associated documentation, female active duty service members had a lower rate of administrative action related to low back pain, which may warrant further exploration. And as with any study, there's always more questions to follow. So for both, the follow-up to the dry needling, the follow-up to any low back pain visit, there was a decreased hazard that first week for female patients, followed by an overall increase relative to male patients. While most research evaluates early care specific to physical therapy as either 2 weeks or a month, the true threshold for early care is unknown and may likely vary based upon patient presentation. It's therefore unknown if there was a clinical impact with a 1 week delay in care, though it's plausible that the 1 week delay may represent a latent variable that was not captured, but could be related to outcomes, which hopefully some of our future research will help elucidate. In addition to helping define thresholds to time to treatment based on patient presentation in a data-driven way that can help with accessibility, it's going to be important to identify how variation of care impacts outcomes and determine dosage with respect to dry needling and truthfully with respect to physical therapy in general. It's unlikely that there's a one-size-fits-all approach for dosage. It's plausible that patients with chronic pain or more complex conditions need more treatment while others need less. However, it's also important to understand at what point a treatment is no longer beneficial. While I'm biased towards physical therapy, I think it's great. It's important to understand that not everyone's going to respond and to make sure that we're triaging and referring out for escalation to tertiary care as appropriate. So incorporating functional outcome measures and looking at who escalates to tertiary care, particularly in patients in those high utilization clusters, is going to be important moving forwards. Next slide, please. And I just want to say extend a huge thank you to everyone on the team who worked on this research that I got to present on today and contributed to this presentation. Thank you.
Thank you so much, Dr. O'Connell. I want to remind everyone to please utilize the Q&A to enter your questions for the presenters, but we'll be holding questions until both presentations have been completed. And now I'd like to welcome the wonderful Dr. Tigno to introduce our next speaker.
Thank you very much, Carolyn. So my name is Senya Tigno. I'm the Associate Director for Careers for the Office of Research on Women's Health, which is part of the Office of the Director of NIH. Now, the Office of Research on Women's Health, which we also call ORWH, leads and coordinates women's health research across the entire NIH. It sets the agenda across the entire agency and its 27 institutes, centers, and offices, and serves as the focal point for both internal and external collaborations. Our efforts ensure an NIH-wide synergy and strategic coordination aimed at advancing women's health. ORWH catalyzes scientific advances in human health by emphasizing the importance of biological sex differences. It ensures that women are included in clinical research and requires that NIH-funded studies account for sex as a biological variable. Our ultimate goal is to enhance women's health, reduce morbidity and mortality, and improve overall well-being. To accomplish our mission, we also promote and support the career advancement of researchers dedicated to women's health. And last year, as part of the increased federal focus on women's health research, the ORWH reached out to the Uniformed Services University to see if we could establish an interagency collaboration to bring a focus on women's health to both our communities. And we are thrilled that this has led to this monthly webinar series centered on military women's health. It is now my distinct pleasure to introduce our next speaker, Dr. Susan Bowden. Dr. Bowden is a professor in the Aging and Metabolism program at the Oklahoma Medical Research Foundation and a research biologist at the Oklahoma City VA Medical Center. She studies the neuromuscular system and its response and adaptation to stressors such as exercise, microgravity, disuse, and aging. Dr. Bowden received her PhD from UCLA and has held positions in both academia and biotech. Her current focus is understanding the mechanisms that regulate skeletal muscle mass and function in response to disease and aging. Since 2017, her lab has been involved in the Molecular Transducers of Physical Activity Consortium, which at NIH we call MOTRPAC, and she served as the chair of the NIH Skeletal Muscle and Exercise Physiology Panel and a member of the Aging Systems and Geriatrics Panel. She was editor-in-chief of the Journal of Applied Physiology and is currently an executive editor of Function and also the president-elect of the American Physiological Society. Please join me in extending a very warm welcome to Dr. Bowden. Thank you.
Thank you for that introduction. Unfortunately, I can't see the slides.
We are in the title slide right now.
Yeah, I don't see them on my screen.
So,
There they are. Okay.
great.
Perfect. So thank you for that introduction. And today I want to talk about the maintenance of skeletal muscle mass and function as a critical regulator of healthy aging. Next slide. So why is skeletal muscle critical for maintaining a healthy life? One, skeletal muscle is one of the largest organs in the body, making up greater than 40% of body mass. Two, movement is dependent on proper skeletal muscle function, and there are over 500 individual muscles designed for very specific tasks within the body. Skeletal muscle also has important roles in glucose uptake and storage, so is important for glucose homeostasis, is a critical regulator of metabolism because of its use of glucose, but also of fatty acids, is responsible for heat production and shivering in humans, and also is a potential source of fuel in the form of amino acids under conditions of starvation and nutrient deprivation. As you can see from this slide, muscle is made up of individual muscle fibers, and these individual fibers have individual specific properties, one of which is the contractile elements made up of actin and myosin. Next slide. So loss of muscle mass and function has been associated with poor health and chronic disease. And this slide shows that sarcopenia, defined as an age-related decrease in muscle mass and function, has been shown to be associated with all-cause mortality, but also poor bone health and increased osteopenia, reduced energy needs, and can lead to obesity, Reduced physical activity and strength is the result of low muscle mass, but also reduced physical activity can lead to a decrease in muscle mass. Also, changes or low muscle mass is associated with diabetes and other diseases. Next slide, please. So skeletal muscle is a complex but very adaptable tissue. As we see in this slide, you can see what we see from the outside individual muscles. But inside, as I said, muscles are made up of these individual fibers, which contain the contractile elements responsible for force production. But muscle also has many other cellular components that are critical for its proper functioning. One is a motor innervation by motor neurons, which form neuromuscular junctions and are responsible then for muscle contraction. Muscle also has a very elaborate blood supply that is responsible for delivery of oxygen, but other nutrients and also waste removal. And muscle relies on energy production or energy sources such as glycogen content and lipids, but also on mitochondria to produce ATP. As you can see in this slide, muscle is very responsive to a number of stimuli, including increased usage or resistance loading, but also decreased loading that can happen during bed rest, and also increased activity that can occur during endurance exercise. Next slide, please. So skeletal muscle, the regulation of skeletal muscle mass occurs over a lifetime. And this graph here shows the regulation or changes in muscle mass and strength as a function of age. This particular graph is divided into three groups, early age and growth, adult life, and older life. And as you can see here that there's a significant or there's a rapid increase in muscle mass and strength during early life that's related to puberty. So growth hormone, other growth factors, satellite cells are critically important during this time frame. Also, increased loading and neural activity are critical regulators of skeletal muscle mass. Muscle mass and strength then will peak in early early adult life in our 20s and for most people, and then plateaus, and we spend much of our adult life trying to maintain this muscle mass and strength. And during this phase then increased loading or neural activity are critically important in being able to maintain muscle mass and strength. And with advancing age, muscle mass and strength decrease in all individuals, regardless of their training levels. But you can see there's a wide variety or wide range in muscle mass and strength. And rapid loss of muscle mass and strength can occur as a response to a sedentary lifestyle, chronic diseases such as diabetes and obesity, but also to an acute illness or injury, and then incomplete recovery, which can then put you on a more rapid decline with advancing age. So the question is, how do we maintain this muscle mass, or what can we do to recover muscle mass and strength after an injury? Next slide. So proper muscle function is dependent on a number of variables. One is the maintenance of muscle mass, which correlates then with increased strength. However, with age, mass itself may not correlate directly with strength because of changes in muscle composition and quality. And this is usually related to infiltration of fat and or fibrosis within the muscle. Another important factor is the nervous system or the neural innervation, and maintenance of proper innervation of the muscle fibers and the neuromuscular junction is critical for maintaining muscle strength and muscle function. As I mentioned, muscle is highly vascularized, and proper blood supply and delivery of blood and oxygen to muscle is critical for maintaining muscle function. Mitochondria content and energy sources, and then also extracellular matrix and tendons are critical for transmitting force. Next slide. So what are some of the causes of muscle wasting or loss of muscle mass as a function of age? There are many variables or factors. A major variable or a major factor can be disuse or inactivity due to a sedentary lifestyle or potentially bed rest or an acute injury and or illness. Neuromuscular junction dysfunction is also a major factor, or in decreases in neuromuscular junction transmission can play a significant role in muscle wasting. But other factors can also play a role. We know that increased inflammation can result in muscle atrophy, mitochondrial dysfunction, vascular dysfunction, and also nutritional deprivation. So calorie restriction will lead to a loss of body weight, but will result in a loss of both fat, but also muscle with chronic food deprivation. In most of these cases, the decrease in muscle mass is related to a decrease in the size of individual fibers. And this slide here, or this section, shows individual muscle fibers stained with a protein that shows the fiber membranes. And you can see that with inactivity or muscle wasting, there's generally what we see is a decrease in individual muscle fiber size, as opposed to a loss of muscle fibers. But you can increase this muscle size, the size of these fibers after acute atrophy with resistance exercise, which I'll talk about in a few minutes. Next slide. So I just wanted to point out the difference between an acute atrophy event versus sarcopenia, and I apologize for this blurry slide. But under an acute atrophy event, such as unloading or disuse, if you look on the graph on the left, you see rapid loss of muscle mass in these different muscles. As opposed to sarcopenia, which is a gradual loss of muscle mass and strength that we see in both males and females. Females tend to have smaller muscles, and so they often reach a critical decrease in muscle mass at a younger age than males, although males may lose mass at a faster a greater percentage over time. And you can see from these graphs, there's with age, and these graphs start at 65 to 90, there's a gradual loss in both muscle mass and also muscle strength. Next slide, please. So I want to talk about two aspects of aging that affect skeletal muscle. One is this attenuated, what we see is a attenuated recovery of muscle mass and strength following an acute atrophy event, and also an increased heterogeneity in the response to resistance exercise. Next slide. So these are data from humans from a group in Copenhagen, and here they had put, these are males, either young males 21 to 30 years of age or old males 61 to 74 in a unilateral whole leg casting for 2 weeks. And the graphs show the size of type 1, the slow fibers, and the fast fibers in control or after immobilization, and then 4 weeks following recovery. And what you can see here is that there's, with 2 weeks of immobilization, there's a decrease in the size of both the slow fibers and the fast fibers in both the young and the old individuals. However, upon reloading or removal of the cast and recovery, you see that the young adults increase their their fiber size back to control levels in both the slow and the fast fibers. But the older individuals do not recover the size, especially of these large fast fibers. The graph to the right shows the effect of disuse on muscle strength or torque. And here again, young and old individuals, in this case, were immobilized for just 4 days in a knee brace, and then had a 7-day recovery with resistance exercise. And you can see in the young individuals, so if you look at pre versus post, there's a drop. You can see that the young individuals have a much greater strength or torque than the old individuals. Following the disuse, there's a decrease in torque in the young, but with 7 days of recovery with resistance exercise, they fully recover strength and actually improve beyond their control levels. In contrast, in the old individuals, you see a greater loss of strength with the immobilization, and they don't recover, they have an attenuated recovery even with resistance exercise. So we've been interested in understanding what is responsible for this greater drop in force in the older individuals in this lack of recovery. Next slide, please. So we used animal models here. The rat, we've used this model called hind limb suspension that was developed by NASA to simulate weightlessness. It turns out it's an excellent model of disuse and bed rest in humans. And here I'm showing 3 different muscles: the soleus muscle, the plantaris muscle, and the tibialis muscle. The red symbols are the adults, and the black symbols are the old individuals. And you can see that we have 14 days of unloading, and there's a significant decrease in muscle mass in both the young and the old young and old rats. And at 14 days, we remove them from the suspension and allow them full ambulation or reloading of their muscles. And you can see that in the adult animals over 14 days, they have a complete recovery of muscle mass in all of the muscles. But in the old animals, there's an attenuated or a failure to recover mass in all of these muscles. Next slide, please. When we measure torque, what we see, so if you look on the right, we have the baseline torque measurements, and then the red dots symbols are after 14 days of hind limb unloading. You see a decrease in force or torque in both the young and the old animals. But even though the young and the old animals lost similar amounts of mass, the loss of strength is significantly greater in the old animals relative to the young animals. Next slide, please. And if we look at then the recovery of strength over 14 days following reloading, we see that the young animals fully recover strength after 7 days. But if you look on the graph on the right, the old animals do not recover any strength during that 14-day reloading. So we have been interested in then understanding what is responsible for this loss of strength and the inability to recover. Next slide, please. So one of the potential mechanisms for this lack of recovery of strength is changes to the neuromuscular junction or neuromuscular transmission. So in order for a muscle to be contracted, the motor axon needs to stimulate the neuromuscular junction and activate these muscle fibers. So what may be happening is that the muscle or the nerve may be pulling away from the postsynaptic junction, leading to denervation of the muscle fibers. Alternatively, there could be changes in the transmission of the electrical signals, leading to inactivation of these muscle fibers. And so with inactivity, previous literature has shown that a number of genes get upregulated. And I list some of these genes here. So we looked at these genes. Next slide. And what you can see here is that these various genes increase in the red symbols are the old, increase in amount, in expression in the old animals. And upon unloading and then reloading, whereas in adult animals, these genes go back down to control levels. In adult animals, these genes stay up, are upregulated and remain high, suggesting that there may be denervation or neuromuscular junction transmission failures. Next slide. This is just another set of genes. Why don't we go to the next slide? So these same genes in a recent study called the SOMA study in humans, which stands for Study of Muscle Mobility and Aging, has been done at the University of Pittsburgh and the University of Florida. And they looked at the same gene signature in young versus, or in older individuals. These are individuals 70 or older. And a number of the same genes that we saw upregulated in the rat are also upregulated in human. And these genes, upregulation of these genes are negatively correlated with both walking speed and leg power, suggesting that neuromuscular junction inactivity or neuromuscular transmission failure or denervation may also be happening in humans. Next slide. So what happens with aging is that nerve fibers that are these motor neurons that innervate individual muscle fibers retract. And when they retract, they lead to individual muscle fibers being denervated. And so other motor axons that will sprout and will reinnervate these muscle fibers. And so what this leads to is fiber type grouping, as seen in the micrographs to the right. So you can see that in muscle, you have different fiber types. These green fibers are these fast type 2X fibers. With aging, you lose these fast fibers. They become denervated, and they get reinnervated by slow fibers, and so which are shown in blue. And what you see then is this fiber type grouping and also this decrease in fiber size. So denervation seems to be a significant problem with aging. And so the question is, how can we maintain these neuromuscular junctions in neuromuscular transmission? Next slide. So one way is through resistance exercise. And this slide just shows some of the benefits of resistance exercise. Not only do we have improvements in muscle fiber size, so hypertrophy, increases in strength, but we also see effects on motor unit integrity or stability of these neuromuscular junctions to maintain this neuromuscular transmission. Next slide. So I wanted to talk briefly about a couple of studies that are being done in older individuals to address this question of response heterogeneity to progressive resistance exercise. And with aging, there is this resistance to adapting to resistance exercise. And what we see here is a schematic of with any exercise program, you often see this heterogeneity of response. So you see some individuals who are low responders who don't respond, while other individuals respond very well, and you see increases in either muscle mass or adaptation. And so we've been interested in understanding why some people are low responders and why some people are extreme responders. Next slide. So we've just at OMRF have just begun a study with a group at IHMC in Pensacola, Florida, that's being funded by the National Institute of Aging, that is specifically looking at the response heterogeneity in older individuals. And so we are recruiting males and females that are 60 years and older, and specifically trying to also get a significant group of individuals 70 and older. These individuals will go through a screening phase, And then they will go through an exercise training phase that will include both endurance exercise and resistance exercise. During the screening phase, we will look at a number of clinical properties, including DEXA scans to get body composition, metabolic health. We'll be doing continuous glucose monitoring, assessing mobility and balance, cognitive function, and also some psychological profiling. We'll be monitoring sleep with the Oura rings, and then they will go through this exercise program. During this program, we will take blood and muscle biopsies from the vastus lateralis at various time points. After 12 weeks of training, we will then assess both their response to the endurance exercise by looking at their cardiorespiratory fitness, the VO2 max, and then also their response to the resistance exercise, looking at functional muscle quality or strength improvements. We expect that about 40% of individuals will respond positively to both the endurance and resistance exercise, but that approximately 10% will not respond to either, and 25% will respond to one, to endurance exercise but not resistance, and 25% to resistance and not endurance. Those individuals that do not respond positively to both will then be given another 10 weeks of augmented training. And the goal is to see whether we can make these individuals that don't respond initially, whether we can get them to respond. Ultimately, the goal is to put all this data into a model to see, can we predict with who will be a responder and who won't be a responder, and who might need an augmented exercise training. So they may need a longer duration of training, or they may need a higher intensity of training in order to be a responder. The idea being that there's no such thing as a non-responder, they just need a slightly different exercise program in order to see significant benefits to the exercise. Next slide, please. And the other study I just wanted to mention is the study called MOTOR-PAC, stands for Molecular Transducers of Physical Activity. This is one of the largest studies to date that's unique in that it's using both looking at preclinical models using the rat and also clinical in humans, both pediatrics all the way, and then adults, sedentary adults, and active, highly active adults who are 18 years and older. And they are going through being randomized either into control or endurance exercise or resistance exercise, and then having multiple tissues, blood, adipose, and muscle removed, taken at various time points for study. In the animal models, we are trying to model the endurance exercise. Here we're taking tissues out at different time points, post chronic exercise, but also after acute exercise. And here we can take multiple organs and have taken out up to 19 different tissues from these rats. All of these tissues, both in animals and humans, are going through a number of omics analysis to try to understand how various tissues and organs respond to exercise. Just briefly, some of the preliminary data that we've gotten from the rats and even the humans has suggested, one, from the rat studies, we've seen that every organ and tissue is responding to exercise in very unique ways. There's also significant sexual dimorphism in the response that we're seeing both in the animal models and the humans in response to exercise. Some of the pathways, we're seeing significant effects on improvements in the immune system and decreases in inflammation, improvements in metabolism. And many of the pathways that we've seen in the animal models in response to exercise suggest protection against a number of diseases, including diabetes, heart disease, kidney disease, inflammatory bowel, and fatty liver. Next slide. So I just want to thank the people that have been involved in these studies, and also the Veterans Affairs and the NIH for funding of this research. Thank you.
Thank you so much. And we encourage you to reach out to the presenters with further questions. And out of the interest of time, we're going to move to our last slide. So also feel free to contact Chrissy Kennedy, and we'll do our best to share the recording of this webinar where you can reference the slide. So thank you all for attending. Our next webinar is Thursday, October 9th at 3 p.m. and we'll focus on the topic of cancer. So scan the QR code to register, and we look forward to seeing you all there. Thank you so much for attending.